Okay, let's talk about service line costing. So in chapter six, we got the department cost to the department level, and now we're going to take it to the actual service provided. So it's kind of the rubber meets the road, the procedure, test, the visit, etc. Uh, and why are we doing this? Because the ultimate goal is to establish prices for our services. So let's dig in a little deeper. So we're taking it to the specific service. So let's, for our purposes, let's just say procedure, test, etc. within a revenue department. So for imaging, it pelvic CT, a head CT, a leg CT, whatever the procedure code is. MRI, you've got codes for all these, but the lumbar view with contrast, etc., etc. Acute acute care may just be a room charge, a day in the ICU, a day in cardiac unit. Dialysis could be a dialysis treatment in center, home, etc. And again, we're trying to price these services because at the end of the day, right, your revenue has to exceed your expenses, right? And knowing your costs and evaluating your costs and benchmarking your costs against other institutions, industry standards to lower them. Okay, so cost reduction, compete key component of healthcare reform. Um, I I teach the first class in the executive program, and I have a whole section on the history of healthcare reform, and it's really geared toward lowering costs. So we have an additional focus on that. So there's kind of four basic methods that the textbook talks about: cost of charge, cost of reimbursement, RVU, activity based costing. So we'll just go over these. Um, Again, I actually did this back in the day with spreadsheets, the same kind you're going to see. And now it's all modern accounting systems, and some of these are historical in nature, but we'll get into that. So we have the textbook example, Exhibit 7.1. We've got some services, we've got some RVUs, we've got some charges, some reimbursements, some direct costs, etc. Indirect costs from the overhead department. As you know, we did the departmental allocation, right? From chapter 6, the previous chapter. We've got some reimbursement. So cost to charge method is the costs are allocated. Okay, the indirect costs within the department that can't be tied specifically to the procedure. I mean, obviously, if you're so this if it's surgery, you can specifically tie the implant. You can specifically tie the supplies. We track supplies on every case. These are all things that are part of the medical record anyway. And then, but nursing time may be allocated by hour. Uh, X-ray tech time that floats around. Pre-admission, the PACU, post-op, pre and post-operative care, the PAT, the intake folks, nurses. So again, there's indirect costs that we're trying to allocate. So in the cost to charge method, what you're doing is you're allocating the costs proportional to the charges. And the theory is that each service consumes overhead costs in the same proportion as the department as a whole to not unreasonable. But the other key component is the charge reflects the level of intensity of the service provided. So you're using the charge as the basis to allocate the overhead of the department on this theory that the charge reflects the intensity of the service. But as we should know from the first class, the charges are not really tied to reimbursement. We all have the story you've heard in the press with the $100 aspirin, right? So the charge master, theoretically it should tie to the intensity of service, but really, it's a big leap for a variety of reasons. I can tell you that in Illinois, for example, every the workers' comp fee schedule, the origin of it, I know the history of it because I've been around, was really goes back to usual and customary, back to whatever 2000 or 2001, whatever they did it. I can't remember. Maybe it was the late 90s. I think it was 2000, 2001. And they codified it based on usual and customary, and usual and customary is a whole other thing. And it some procedures, if we look at it in relation to Medicare reimbursement, which Medicare theoretically is tied to some kind of RVU. I mean, there are some procedures that pay, 100% of Medicare, some that pay 300% of Medicare, and then we set our charges based on the workers' comp fee schedule. So you've got you know workers' comp fee schedule driving where we set our charges because payers reimburse the lesser of the contract or charges. So you never want to bill a payer less, right? You never want your charge to be less than your highest fee schedule. And for the most part, not exclusively, but let's just assume that work comp is the highest fee schedule in Illinois. So you don't want your charges to be less than that. But if the work comp fee schedule was based on this kind of archaic thing way back when, usual and customary, and it really has no relation to the intensity of service, especially as things have evolved. As total joint surgery has gone to outpatient and the intensity of service has dropped. It used to be a week in the hospital, right? Now it's patients are mad if they're not out in 4 hours. So, you know, charges are inflated. They really don't. Do they tie to reimbursement intensity of service? I would say no, especially as technology improves and the intensity shifts. So we'll go through the example just for the educational benefit of it, and then we'll talk about it a little bit more. So basically, we have our services, we have our RVUs, we have our charges, we have our reimbursement. These are given, these are assumptions that are given by the problem. So if we were going to allocate the indirect costs of the department to specific surgeries, let's say we would start with our charges and of $2.1 million, and we would have our indirect costs, and we would say that indirect costs divided by total charges are 14.3%. Right? So indirect costs, which was given by the problem as 300,000 divided by our charges is 14.3%. So we apply that ratio, that percentage to the charges for service X and service Y, and we say that 100,000 of indirect costs is applied to X, 200,000 of indirect costs is applied to Y, and we add them together because we always want to check our work. How much, that's 300,000. What were we looking to allocate? 300, right? We learned about that last time. We're checking. So we have, let's do a P&L then. So we have service X at 5,000, service Y at 5,000 to make it simple, I guess. We have our reimbursement, 400, 900,000 given by the problem. Our direct costs from the cost accounting system were 242, 485. We allocated the 100 for service X and the 200 for service Y. Our total cost 342 for X, 685 for Y. Our profit 400 less 342, 57 and change. 900 less 685, 215. Does it tie out? Yes. Profit of X and Y equals profit of overall. Now we want to say what is our cost for the service. We take our cost for the service, and I don't know if that's showing 348, 334,000 and change, 692 and change. We divide it by the number of the volume, and so we get $66.90 for service X, service Y 138. So theoretically, we would make sure that our reimbursement per test on average is greater than these numbers. So we're allocating the indirect costs based on some ratio of indirect costs to charges. Okay. The next one, to charges right here. The next one we're doing is cost of reimbursement. So this would be the insurance company's fee schedule. So we're doing it not based on charges, which we know are inflated and silly to some extent. Reimbursement is probably a better because it reflects what you're actually getting on average, and perhaps if it's an average, other United or Blue Cross, they've applied some methodology. Basically, everyone's percent of Medicare. So you're hoping that Medicare has used a rational methodology to establish reimbursement, and I think for the most part, relative to each service, they probably have. Although there is some recent items in the news where there's some criticism of Medicare's approach, and perhaps they devalue primary care at the expense of specialty care. They devalue, the good old fashioned primary care, working, assessing patients, working them up, etc., versus surgeons who do things with a scalpel. I'm not going to get into that, but there has been some recent noise in the media, or in Congress, I guess, or CMS, about maybe it's out of balance. But neither here nor there. For this purpose, we're using reimbursement, the ratio of our indirect costs to our reimbursement. So instead of charges, we're looking at our total reimbursement, which by definition of the problem was 1.3 million. And so we're applying a factor of 23.1% relative to reimbursement. So we take our reimbursement as opposed to our charges in this example, reimbursement here, and we take our reimbursement times our allocation rate or percent of 23%, and we apply 92,000 and change to cost to X and 207,000 and change to Y. And then we set up our P&L the same way. We have our reimbursement for X and Y, we have our direct costs for X and Y, we take our indirect costs as allocated, we come up with a P&L for each one. Again, we do our checks. Does it tie out? Does this tie to that, etc.? And then we take our total cost divided by volume. In this case, we get $66.96 for X and Y, 138.54. And again, we would make sure that you know our contracts on average are greater than this cost. I mean, again, in the first class, I talk about how Medicare does not. Medicare is basically priced on the margin, which we'll talk about next to some extent. Medicare really doesn't cover the full cost for the most part, which is somewhat problematic, but that's a story for another day. But you see what you've done is you've allocated it based on reimbursement. The RVU method, which really came in the really in the 90s. So the RVU method, the relative value, you're looking at the relative consumption of one procedure to another, right? So you're looking at how much resources are consumed in open heart surgery versus a day in the hospital versus an office visit. And in the 80s, I mean that's a standard cost accounting principle. So in the 80s, when I did this for the, I did actually did this very thing for a hospital as when I was finance director, and there were no published RVUs. We figured it out. We for everyone. We we established a relative value unit for a day in the hospital. We established it for basically every procedure that was done. It was a big job, and we did it by department, and I worked with the clinicians and et cetera, et cetera. But it was a huge job, and there was no standardization across other institutions, nobody was really doing it. It was just too much work. But we did it. In the 1990s, we came up with the relative based resource value system. Is that, I think that's right. RBRVS, resource based relative value system. Sorry. And so prior to that, Medicare was usual, customary, the reimbursement percentage, 50th percentile of this. There was Milliman, not Milliman Robertson, but somebody else. And Medicare hired Harvard, said, look, for every we need to rationalize the way we pay, and so we're gonna create we're gonna hire you to figure out relative values for every procedure in the procedure code book. What is it really? What resources are concerned? And I believe they said a 99213 in an office visit is a 1. We're going to pick it as a 1 and we're going to benchmark everything off a 99213. I may a little bit have my facts Not 100%. It's a little musty, but that's essentially it. So we're going to say a 99213 regular office visit is a 1, and then we're going to go from there. And a open heart surgery maybe a 3,000, whatever. They're all published. You can a little more complicated that, but in a nutshell, that's it. So that once you became standardized, well, first you didn't have to invent it yourself. You could just download it. I think that well, I don't know if you could download it in the '90s, but you could, or you could buy a disc, and you didn't have to do it yourself. It was published. And the other thing that made it was you can then compare it to other institutions because everybody was working off the same RVU system. You know, and so now you could benchmark. So that was a boon. I'm not saying it was the perfect data set in the world, but it was really a boon to cost accounting. It really revolutionized the field of certainly service line costing overnight. So what we do here then is we're going to allocate it based on RVUs. So we have our same indirect cost of $300,000, and we've said we have 140,000 RVUs, and we've that have been used because we have RVUs per visit, right? And so we have 5,000 times 10 and 5,000 times 180 or times 18. So I believe if you do that math, well, here it is done for you. 5,000 times 10 is 50,000 RVUs. 5,000 times 18 is 90,000, a total of 140,000 RVUs. So we have a $2.14 allocation rate per RVU. We apply the allocation rate to our RVUs. We get 107,000 and change for service X, 192,000 and change for service Y. We bring them down to our P&L. We compute our P&L. We take our cost divided by 5,000. We get a 69.93 cost for X, 135.57 for Y. Again, we compare it to our reimbursement. So then the final one we're going to talk about is like activity based costing. So now what we're doing, instead of allocating certain of these costs, these indirect-ish costs, by a method, we're trying to get way more granular. And basically, I mean, the textbook's a little behind, maybe an updated version. You know, this is made possible with modern EMRs. This would be very difficult and very expensive, and there are people did it before EMRs really became what they are today. And they would hire consultants, and they still do to some extent, measure what time it took things. But really, with the modern EMR merging with the accounting data, you can you, you supersize your ability to do this the same way that the RVRVS system supersized your ability to do an RVU approach. EMR, an Epic type system, a Cerner type system, with all this clinical and financial data in one huge database, and barcode tracking and everything else that's done, that the clinicians know way more about than I do. It's really made activity based costing more viable. We'll sum it up at the end. So we're identifying the relevant activities that create the 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 service or the product, and then we estimate the cost of the services. We do the same kind of driver and activity data, but as you'll see, it's much more granular. So let's say that we use this example in the textbook. We have a series of, we have 7 activities that are performed by this department. We're checking patients in, we're doing a preliminary assessment, a diagnosis, a treatment, we're writing a script, patient checks out, we do a billing. Again, these are services that are provided for all the specific services. These are activities that are done for all the services that are provided to the patients. And they're indirect in nature as opposed to, the specific maybe supply costs that you could possibly charge, that could be directly attributable. So let's just use the example. So we get this example from the accounting system. I'm going to go ahead and load up Excel just to make it a little easier to follow. Give me 1 second. Sorry. Okay. So I think that'll make it a little clearer. So we've got sorry, make this a little easier at the end. Okay, make it a little easier. Okay, so we have our data table. I like clean, orderly data tables. We've defined our costs for all the activities. We know what these various activities cost because we have an accounting system that has categorized these costs in these various activities. And we've defined what the cost drivers, how do we want to allocate these costs. So check in, we're going to allocate it by the number of visits for each of these services, X and Y. Assessment, we're going to do minutes per visit, and maybe we've tracked. No, we've tracked the costs, but we've done some studies, and we say, well, on average, there's 5 minutes of assessment for procedure X or service X, and 10 minutes for Y. Diagnosis, it takes 10 minutes to diagnose X, 15 for Y. Treatment, again, 10 for X, 20 minutes for Y. Maybe this is my buddy's urgent care company. Prescription, on average, we do, let's say for 5,000 visits, we've done 2,500 prescriptions for X, so it's an average of a half per X visit, and Y, more intensive, we write it's two drugs for Y. Uh, Checkout time is we're just going to do it by the number of visits because it's about the same minutes wise. And then bills, we send out one bill for X, people pay it. Y, maybe it's more expensive. Maybe they don't understand it. It's like it's like fracture care and orthopedics. We get a call like one a day about that. So we've defined these. These are given. So how do we then do the allocation? So the total usage, we're going to do the usage, and again we're linking. So we've said 5,000 visits. We're doing it by visits. We've linked to 5,000, right? And let's just do this because that'll make it easier. Um, I'll make it easier to see the linkage. Okay. Um, and then here's where it gets tricky. Here's where the students, if they get it wrong, here's where they get it wrong. The assessment, we have total minutes. So we have to take the visits times the minutes per visits to get total minutes. Okay? You see that? We've taken the visits times the minutes per visit to get the total minutes for X and Y. And that's where in the homework the students kind of miss that aspect. Visits, a visit is a visit, and we've just assigned it as number of visits. These other ones were saying minutes per visit, so to get the total minutes, we have to take the minutes per visit times the number of visits. So the assessment, the diagnosis, it's the visits times the 10 per. Nothing is hard coded. You'll see how everything is linked. Okay, so again, the same with each of these minutes. We've got to multiply it by the number of visits. Uh, the drugs, the same thing. It's total drugs would be the drugs per visit times the number of visits. Okay, you see we've linked, not embedded anything. So the total visits, and then checkout, it's just the visits. So we just bring in the number of visits. And then the bills, same concepts with the minutes. It's 5,000 times 1 or F11 times F5. And this is 2 per times 5. Now again, why do we build models for the millionth time? Let's say somebody says, you know what, things are tough. It's now taken us 1.5 bills for X, and now everything just flows through. And everything, okay? You don't have to change any formulas. You don't have to there's a new all-in-one drug, so it's gone from 2 to 1, and it just happens. So that's why we build models. Okay, so we've got then we have our annual costs to be allocated. We've linked those, right? And then we take our driver totals. So X plus Y equals the total for that driver, right? So we've added that together to get 75,000. We've added those together, right? You see a theme, totaling the driver. So we take those annual costs divided by the driver totals and we get an allocation rate. So it's $5 per minute, $1 per visit, $2 per, or sorry, dollar per minute, $2 per minute, $3 per minute, 20 cents per drug. Not the cost of the drug, but the prescription. Uh, and it's $5 per visit for checking out, and it's $10 per bill. Okay, so we've taken the cost of providing that service divided by our driver totals, and we get the allocation. We've also added up our costs here to make sure it ties there because we're good Excel modelers. Now, then we just have to apply it. We take our allocation rates. That's where they came from, right? So we've taken these rates and we've referenced them over here using Excel. And again, we always want to do spreadsheets that we can send to somebody and they don't have to ask us a question, so we're very anal retentive. And we say allocation rates $5 per minute, per visit, per minute, per minute, per minute, per drug, per visit, per bill. So nobody has to ask us, it's very clear. And then we take our usage. So for X, we've linked it. Uh, no, X, we've said it's one check-in. I'm sorry. We've per visit. There's just a one-to-one ratio visit to itself, right? So the usage is just one. Each visit is one of itself, and then kind of by definition. And then for X, we've linked it to the five. Um, F6, F6, where are you? F6, there you are, right there. Um, and we've linked it back to our data table. Um, so X diagnosis we said was 10 minutes per visit. So we have our 10. Treatment we said was 10 for X. 0.5 drugs visit. A visit is a visit. A bill we said was 1. We've linked to the F11. And then we've taken the allocation rate times the usage. That's 5, right? That's a dollar times 5 per is 5. Diagnosis is $2 per minute times 10 minutes is 20, et cetera, et cetera, et cetera. So we get a cost per service of $75.10. With service Y, let me just make this a little cleaner. Again, we've linked a visit is a visit, so it's 1. We've said 10 minutes for assessment, 15 minutes for diagnosis, 20 minutes for treatment, 2 scripts per visit. Checkout, a visit is 1. Billing, we said 2 bills per. And then we've multiplied those times our allocation rates. We've come up with $130. We always want to check our work, right? Yes, we do. So we take our cost per service, we multiply it by the number of visits that we've linked to the assumption table. We add the two together, 75 times 5,000, that 130 and change times the 5,000. We total them together. We say, what were we trying to allocate out? We're trying to allocate out this. Should be 0. So it's just a little bit more detailed. Okay, we're gonna do one more. 7.9. It's in the appendix. While we're kind of feeling saucy here, so I'm going to do this. Just change this so that it's easier to follow. In this case, we had annual costs as defined. It's actually problem 7.9 if you want to look at it. We have service levels, visit volume, again, service A versus B, assessment 15 minutes versus 8, 20 minutes versus 10 on diagnosis, treatment 5 minutes versus, on each. Again, visit volume, checkout, we're going to do it based on visits. Number of bills, service A is 3 bills on average, service bills B is 1 bill on average. Okay, so we take our annual costs. Visit is a visit, so we've linked it, right? We total the visits. We take our annual cost divided by our total to get our allocation rate. We do that again. This is where people mess up. Total minutes is the visits times the minutes per visit, minutes per service, which is a visit. So we take that visit volume times the 15 minutes to get the total minutes. And then for service B, we do the same, only it's G6 times 8. So again, we do the same thing down each of these to get up the total minutes provided. We do the allocation rates. We take those allocation rates, we bring them down here. Again, neat, orderly. Everything in green is linked. There's no embedded assumptions. And then we have our per visits. And then we take, and then again, just a different little format. We take our dollar per minute times the number of minutes, which was 15 for test C. Oh, test C, that's service A. Huh, it's not good. Um, I think I modified this, so apologize about that. So we have service A, service B. Okay, so we 455 for each visit. For check-in assessment, again, it's the allocation rate times the minutes per service. Allocation rate times the minutes of service. Diagnosis, the allocation rate times the minutes of service. I think you see that working now. Bills, allocation rate times the number of bills. Allocation rate times the number of bills, which is the one. We total that up. There's our cost, $143 of indirect cost, right, for providing that service. Indirect costs for providing that service. Now we want to check our work. We take our number of tests or service. I'll just say visit volume. And we take our whoops. Okay. So obviously I didn't update this, but it kind of shows you at least how easy Excel works. I'm going to just say I did it on purpose, which is not true, but let's just say I did it on purpose to demonstrate how easy Excel is. So I have my volume, service A and service B. I've linked. I have my cost, right? 143, 101, right? And then I multiply the volume times the cost. I get a million for service A, a million for service B. I add them together, comes out to 2. I say, what was I trying to account for? And there you have it. So, two examples, a little different format. You're going to be provided a format in the homework, but you can see it's well ordered if I get the headings correct, and pretty straightforward. It's just a little bit more complicated. So let's go back to, and that was 7.9. Let's go back to the lecture. Okay. Yeah, that was 7.9. So we summarize the results um, uh, of the various methods. Okay. So let's just summarize. Cost of charge. Nobody's used cost and charge since the 80s. Again, I already kind of explained this. Charges just don't really have a relationship to intensity of service. So nobody uses cost of charge. Cost of revenue, it's more better, but why would you use it if you have RVUs? So RVUs is very common since each CPT4 code has RVUs. And if you look in a modern, if you look in that deck, that handout on cost accounting systems, RVUs is easy. It's benchmarkable. It's standardized. Every procedure code has an RVU. Rock and roll with RVUs. Activity based, theoretically the most signed. We're tracking actual activity used. It really just depends how much you kind of want to rock and roll with your EMR and your billing system or your accounting system. Your and maybe I think most do a hybrid. There may be some areas that you really want to get very granular, and so there's you might do a hybrid, but it's really hard to argue with RVUs because you can download the RVUs for Medicare, the work RVUs, and you can basically rock and roll. Activity based, with modern EMRs, you want to put in the effort. It can be pretty point and click. The textbook mentioned this, so I'm kind of honor bound. This time activity based costing, their costing should account for the total cost of resources used as a patient traverses the healthcare system. Yeah, I don't really see this as a separate method. It's really not a method. It's an application of what we just talked about. It's not a separate method. First of all, patient outcomes is completely separate from this kind of accounting. And if you want to track the patient's, and again, when you the value based care, we talk about that. We're unequivocally doing that, but it's an application of service line costing. You're using RVUs or activity based, and you're tracking. It's just not a separate method. It's just an application. And if you look in the in the Spence Kanzler handout, again, select the condition to be studied, define the activities of the care delivery chain. Those are procedure code based. They're not check-in registration. They're procedure code based. So you've already done that indirect process map, estimate the cost of each activity. Again, you've already defined the cost with the procedure codes. It's for purposes of what we do call it. We call it service line analytics. So again, it's not a separate method. If we look at the Spence Kanzler, redefine service lines across the organization. So we're looking at how do you treat a total hip from you know in patient education, preoperative education by a nurse or clinician, or if we do it internally. Hospitals were big on it, but a lot of orthopedic groups have taken that over. Quite frankly, because we don't want the patient to just go to inpatient rehab because the hospital makes more money. Sorry. to be frank. We've taken that over, and a lot of hospitals don't necessarily follow physician protocol post acute discharge. Again, sorry, but that's my experience. So, and then through the treatment, and we defined it outside of the course of a specific institution. So we've done this analysis from the clinical side, from the surgery center side, from the skilled nursing or inpatient rehab to the home health side. So we've defined the state of the art is service line analytics beyond just what happens inside the four walls of an institution. So again, a little pedantic of me, but it's really not a separate method. It's an application of these methods. Okay, we already did this, and so we're done.